white blood cells, you got to know them because we're going to be talking about itises and infections, and you need to know your white blood cell count. You should know your H and H, what kind of a normal range is. Be able to recognize something really out of range. Because if somebody's H and H is really low, not just a little low, but like their hemoglobin is less than 9, and their hematocrit is like in the 20s, there's a perfusion problem because you don't have. Remember, your hematocrit tells you your cell volume, your red cell volume, and so and the hemoglobin is the portion that carries
oxygen to the body.
So you can't perfuse well. You got a perfusion problem if your H and H is low. Platelets you need to know because you got a bleeding problem if your platelets are low. You got a clotting problem if your platelets are high. Does that make sense? INR you should know because if the INR is 3 or greater, that patient's blood is what? Thin. And they're at risk for bleeding if they have any invasive procedures. That make sense? Yeah. Okay. And you should kind of know a normal PT, but it ain't going to kill you if you don't. But you really need to know it, what normal is. Do you see fibrinogen and D-dimer and all that other garbage? That's just for clinical. If you have a patient that has that and you're wondering what it means. All right, you should already know you want cholesterol of anybody less than 200. You should know your triglycerides. Kind of know that. Be able to recognize a troponin that is elevated. If it is normal, then it is going to be the number on the screen or less. All right? But usually the number is not going to be on the test, it's going to be abnormal. Okay? So you should be able to recognize it. CK&B is 0 for you. At Singing River Hospital, that's not the number. At Gulfport, it's a different number. At another hospital, it's a different number. On the PowerPoint, it's a different number. So I want you for your test to follow these numbers on this lab PowerPoint. You with me? But really, it's going to be so off that it wouldn't matter anyway, whichever one you looked at. So I pulled this up because I've had a lot of questions from the other section too. Which number are all different? So which numbers are you going to use for your test?
This lab.
All right, this one right here. So the only other thing I was going to mention to you is this is not on your test. The homocysteine is not on your test, and neither is the CRP. But I like for you to know it for general information that if your homocysteine is elevated above 14, then that kind of puts you at a high risk for cardiovascular disease and stroke. And CRP also is the same thing. If you have a lot of inflammation going on in your body and it's in your vessels, then you are more at risk for atherosclerotic plaque and cracked plaque. So that's just risk, okay? So that's just FYI, and don't memorize that. Your electrolytes, you should know what a normal creatinine is. You should know your normal electrolytes, especially potassium, magnesium, and calcium. And sodium's just easy. You should know that. Okay. Now, ABGs, you should kind of know the norms for those. And that's it for that, okay? Now, I put this extra up here. So not to freak you out, but to give you an idea of something. You do not need to know this for your test. But I'm fixing to get in a PowerPoint that does not have this. And some people say this helps them. Okay? when we're fixing to start talking about, or I'm going to fly through angina and MI to make sure you know what you need to for the test. When we're talking about somebody having an MI, we say ST segment elevated in 2 leads, and we say 2 contiguous leads. That word means 2 leads that are looking at the same location of the heart muscle. And that's why we do the 12 lead, if you remember, because we're looking at different directions and areas all around that heart. We can't do that with a regular telemetry. If you work for an ambulance, or if you are new to the ER, then they carry these little reminders about where these leads on the 12 lead are looking. Which part of the heart muscle is that lead looking at? So that they know if they are contiguous leads, that the ST is elevated. They don't even know. Some of them know. The doctors know, the seasoned nurses know, but some of the newer ones will not. So they may have something like this on their badge or on their clipboard, and that's what it is. So lead 1 is looking where? Lateral. Lead 2 is looking where?
Inferior.
And 3?
Inferior.
So if their ST segment's elevated in 2 and 3, is that 2 contiguous leads?
Mm-hmm.
Are they having an MI?
Yes.
If it's significantly elevated, not one little bitty box or something, okay? All right, that's all I want you to know. Is that on your test?
No.
So forget about it. If that didn't help you, I'm sorry. Got that? Okay. All right, I'm not going through the stuff I've already covered, but I want to show you this. If the renin-angiotensin-aldosterone system bothers you, you can click on that little link, and there's a little video talking about it. It's really short and sweet, okay? All right, risk factors, you remember those? I'm not going to cover those. But health problems, and when you're taking your database, if they're complaining of these kind of things, then could that be cardiac? Be related to poor perfusion? Yeah, pain, fatigue, palpitations, all of that. And by the way, I have a question. Let's see if you can put it together. You know, you nurses. If I have a permanent pacemaker, I'm not hooked to a telemetry on your floor, and I tell you, all of a sudden I'm having palpitations, I'm dizzy, I'm weak. What could that mean? That my pacemaker is not functioning. You as the nurse need to know the signs and symptoms of pacemaker dysfunction, malfunction, because you will see that. I see it out in Walmart. There's a little old man, and everybody's freaking out because he had done lost the color out of his face. And everybody runs, and I'm like, why is everybody running? I'm like, is there a shooter? You know, I'm fixing to run too. After seeing that video they showed us here, and then I thought, I can't do that. And so I looked at my husband, I go, come on. And he picks the phone up, 911, he's not on it, you know, and with his job. And so I'm telling the man, just look, I'm going to lay you in the floor. Why am I laying him in the floor if he's pale? Could he fall?
Yeah.
And so also, could I get some perfusion to his head?
Yeah.
And so we talked to him and all, and then I saw, when I started looking at him, I saw his pacemaker. I was like, when's the last time you had your battery changed? Oh. So I'm feeling his pulse, and it's like 30. And I'm like, oh, please don't stop. And so, that's what I was thinking, I didn't say it. And so they came, got him, and so you need to know it, because you might be at the Walmart like me, trying to put 2 and 2 together. Going, I can't run. I can't leave this poor man. All right. And then I had to explain to Linus why it took me so long. All right, Linus is the dog. All right. All right, so we've already talked about the signs and symptoms of low cardiac perfusion. Do you think you need to know those? Yeah. Now, let me ask you something. Would you think it's very serious if someone was confused and dizzy and had a low urine output? That would probably be real significant, what? decreased cardiac output. As opposed to someone whose heart rate was a little elevated or blood pressure was a little low, right?
Yeah.
So you, as the nurse in level 3 or year 2, are going to have to learn how to now pick which patient you would see first. It's not just knowing it, it's applying it. All right, so we've already covered all this stuff, but let me make sure. You have to know, let me ask you this question just to make sure. We're going to talk about pericarditis. And with pericarditis, you remember I told you that was the inflammation of the pericardial sac?
Mm-hmm.
When we start talking about pericarditis, one way we know patients have pericarditis is a clinical finding known as a pericardial friction rub. But people can have the same rub sound coming from their chest. The location that it could be coming from is their lungs. Because you can have weird rubbing sounds coming from a patient's lungs, or you can have it coming from their heart. So how can you figure it out? Ask them to hold their breath. And if they hold their breath and you're still hearing the rub, guess where it's coming from?
The heart.
Their heart. So I just like to make sure you know this kind of stuff, because you're going to be home alone, not too long, and you got to talk with some sense. And so if you say there's a rub, you need to tell a healthcare provider, you can say, I had them hold their breath, and I still hear it. So I think it's coming from their heart. Y'all got it? Yeah. All right. So you hear a click if they have an artificial mechanical valve. Do you need to know ape to man?
Yes.
You need to know where to take an apical heart rate? Yes. Okay. Which, you see the CK&B on this PowerPoint? Is different than yours. That's the one that I had gotten from Singing River a little while back. The one on your test and in your IGGY book is 0. And why do you think I'm letting you use that?
It's easier.
It's easier. I want you to do good. But I also want you to know at different hospitals that what? Different. All right, we talked about that. If you want to know microalbuminuria, where's that located? In the pee? And that, if you have people spilling albumin in their urine, then that means that they have some, possibly some kidney damage. And that's a marker for endothelial problems. So that's a risk factor for cardiac disease as well, okay? Who cares? But I like for y'all to know stuff. Here's again some stuff about cholesterol and interesting facts to help you with that. Same old stuff that we have on our lab PowerPoint. We've already talked about 12 leads and echocardiograms, hadn't we? Y'all know how to teach a patient going for 12 lead. You know how to teach them going for an echo, right? Okay. That's showing you a patient on a 3-lead telemetry monitor. This is talking about other cardiac testing. We talked about a stress test, exercise yesterday, and a pharmacologic stress test, didn't we? All right. We've already covered hemodynamic monitoring. Can you tell me, without looking up here, what a normal cardiac output is?
47 liters.
All right. Now, remember I told you that you didn't have to write this down, and I had already written it on the board, but here is the how you get a patient's mean arterial pressure without a monitor. Because I hear all the time, well, it's right there on my blood pressure monitor at work. Well, guess what? Your blood pressure monitor is not going to work if the patient's blood pressure drops too low. So how are you going to be able to talk MAP with the doctor? And why would you talk MAP with the doctor? What did I tell you MAP stood for? How much perfusion is going to your major organs? And it needs to be at least 60. We like it between 60 and 70. We actually like it higher than that. But the lowest, the absolute lowest that will perfuse your organs is 60. All right? So here's how you do it. 2 times the diastolic blood pressure, and that's in parentheses, so you do it first. Plus the systolic blood pressure divided by 3. So y'all want to do one? Do an easy one. 70 over 30. So 30 times 2 is 60 plus 70, 130, divided by 3. You tell me what it is. We struggled with this yesterday. Y'all are too. They're getting their phone out. 43. So it's 43. Is that less than 60? Is that patient's major organs getting perfusion?
No.
Do you need to contact somebody? Okay. And if you tell Miss Gary I didn't teach y'all that, I'll beat you slowly. Because she's going to need you, you're going to need to know that for her content to get ICT. All right? Okay, so go ahead and learn it. All right, do you remember CVP or RAP and what the normal was? And if it's too low, they dry, and if it's too high, they wet. Do you remember all that? Do you see this next picture? Don't worry about it. We're going to cover that in level 4. And that's hemodynamic monitoring and how we can get those numbers with a pressure monitoring system. Don't worry about it. Coronary artery disease, if you don't remember what these definitions are, there it is. And this talks about stable angina. We've already covered that in level 2. If you don't remember it, there it is. What you're responsible for in level 3 is this. Unstable angina and MI, but primarily MI. Hint, hint. But you need to know the difference. So, again, unstable angina, we've talked a little bit about it, but I like visuals if I can keep them on the screen. Normal ST segment is the one on the left on the strip. ST elevation is the one in the middle, you see it? And then the depression, the ST segment falls below baseline. ST segment elevation means, you tell me. What does it mean?
Depleted oxygen.
These 2 leads. What is STEMI? All right? And you can tell the difference between unstable angina and an NSTEMI by how? Lab evidence. If troponins elevated, we are having an NSTEMI. If it's not, we're having unstable
Angina.
Okay. You remember risk factors? They're all on here for you to review if you forgot them. Diet teaching. The 2 diets you're responsible for in cardiac are DASH diet and TLC diet. They're right there, so you don't have to look them up, dig them up from nowhere. Now the deal is here, the main thing with cardiac is low sodium, low fat, low cholesterol. So, do you remember all the foods high in sodium? Spout them out.
Potato chips, pickles,
Any canned food.
meat, sandwich
What kind
meat.
of juices are
I didn't
high?
meet.
High in sodium.
You said juices?
The kind y'all don't drink.
Tomato.
Bloody Mary.
Oh.
Tomato. You ain't right.
I don't like tomato.
All right, well, it's high in sodium. High in sodium. Tomato juice is high in sodium. Cottage cheese, high in sodium. A lot of processed cheese is high, and anything tastes good is high in sodium. Sorry. All right. So we've talked already about acute coronary syndromes and atherosclerosis and MI, and here's just a really cool little study guide for you, telling you what's happening. We've already talked about STEMI and NSTEMI and how to tell the difference. And so in ischemia, we can see sometimes ST depression. And in part, what do we see?
ST elevation.
Good. Now this is real important because you need to understand with MI, they're going to have those associated signs and symptoms more so. Now when a patient starts becoming unstable angina, they're just moving towards MI. They're moving in that direction. So they may have some of these signs and symptoms too, but they're getting close to MI, okay? So with an MI is where you're really going to start seeing some associated signs and symptoms, such as, what do people tell you? nauseated, I gotta vomit, you know, oh my gosh, my chest is feeling heavy, but what about women?
My back, my jaw, my neck, my shoulders.
Indigestion, something weird. So always remember that. It may just be weakness. So know that. Look up about a woman. But tell me about an older adult. Are they going to present with all these typical things?
Decreased level of consciousness.
Confusion, change LOC. And they may not be able to tell you, my chest hurts and my left arm hurts. Okay? And did y'all remember that when someone has a pretty significant MI, there's a pretty significant area of their heart that is damaged, that it's going to cause a fever? That patient's temperature is going to spike up. And the reason that happens is the little white cells are trying to clean it up. So they all go to the spot to try to clean all that dead off of your heart muscle. So having a temperature elevated for a few days is normal. And I'm talking 102. So that's normal. I've followed a pretty big MI. And their white count's going to be up too for that reason. Okay? All right, so here are our cardiac markers, otherwise known as enzymes, that you might possibly have. Remember, myoglobin is not significant for the heart. Which ones are? Troponin, IT, and CK and B. And here is what's on that one page. It talks about, gives you an idea of when these enzymes are detectable in the blood, when they peak up at their highest, and when they're going to start to do what? Start falling, and then when they're no longer what? Detectable. So let's talk about this. So if my brother comes in because he has gas and he's afraid he's going to die, and he just started having his symptoms 30 minutes ago, his enzymes are going to be what? Normal. If it's been a couple of hours, then which ones might pick it up? Which one's going to pick it up first? Myoglobin. So we're going to go, ooh, we better watch him. You see what I'm saying? That's where myoglobin helps. Now let's flip the other coin. If a patient comes in and says, well, I was having chest pain about 5 days ago. Which is the only one that would detect it? The troponin. So is that important to know? Why do you think I just went through that?
It's chest
Might
pressure.
you see that? But really, that's really useful information for you as a clinician. That's very important. So do y'all see that there's a problem on this slide? Oh. I say, oh, we got a tombstone. That ain't good. Tombstone's never good. So you don't even have to look twice at that to tell there's 2 segments on it, do you? That is in the acute phase of a pretty bad MI. And they need to be going where? As fast
Cath lab.
Cath lab, as fast as we can get them there. All right, so you remember Mona in the right order on a nasty morning. And so we're going to position them to the rest position always first. And then we go through the oxygen and all of that. Okay. There's some helpful little things that this instructor has put in about meds for you. You can read it at your leisure. Revascularization is very important when we're talking about an MI. Time is muscle. The longer we allow the damage to occur because there's lack of blood flow, the more heart muscle is going to be damaged. The more heart muscle damage, the lower the quality of life the patient's going to have and whether they're going to survive. And so what did I tell you was the #1 complication that kills them? The most common? Dysrhythmias. Remember that. Because that's why there's AEDs out there in the public, and that's why we need to use them. Because if somebody tries to drop dead from that following an MI, we can get them back, get them to the hospital, and they can live a very quality life. The other way that we can open up a vessel if there's no cath lab up in Leaksville is thrombolytics. On page 778 in your book, it tells you the absolute contraindications of thrombolytics. And I can tell you that you are going to be tested on thrombolytics. You're going to need to know which patient is a candidate for them. And so you're gonna get 4 patients that come in, and you're gonna have to determine whether they are a candidate to safely receive thrombolytic therapy, such as alteplase. There's some other ones, but I don't think they're FDA approved or on the market, and they're hard to get.
What was the page number again?
778.
Thank you.
Uh-huh. And so thrombolytics, we can't give thrombolytics to anyone who has a malignant brain tumor. We can't give thrombolytics to anyone who had a recent, within a couple weeks, surgery. We can't give thrombolytics to someone who's had a recent trauma. We can't give, does that make sense?
It's
Iggy in the 9th edition, isn't that the one y'all have? Here, I'll show you. Let me show you what it looks like.
Brain tumor surgery and childhood trauma.
Iggy?
I know which one.
Oh, okay. I got it in my thing if you need to look at it. All right, so, again, thrombolytics are important if you don't have a cath lab. But are they dangerous? We give a bolus after we have done the checklist to make sure that the benefit outweighs the risk. You heard me say benefit outweighs the risk. In order to get thrombolytics, the patient's chest pain had to last over 30 minutes. Does that make sense? And it has to be a STEMI, which means it's a significant problem. A STEMI, not an NSTEMI, a STEMI. And because these heart attacks, MIs, evolve over about 4 to 6 hours, we don't want to give it if the patient's presenting more than 6 hours. Does that make sense? Because the damage is done. Why would we, you know what I'm saying? Why would we risk thrombolytics if the damage is done? Because we can kill them with thrombolytics. Because what do thrombolytics do? They dissolve the clot. And so if they dissolve the clot and they had a recent surgery or a recent trauma,
They're at risk for bleeding.
they're at risk for bleeding, and we can bleed in their brain and kill them with it. So what does PCI mean? Percutaneous coronary intervention, such as a balloon angioplasty. So I just want to make sure you know what that meant. And so that means take them to the cath lab and get in there, open it up, and send them in the cath lab. And if we can't get them stented, we can't get the wire in, we can't make it work, they may end up having an emergency open heart surgery called a cabbage. All right, so we know, we talked about cardiac catheterization. What are we visualizing a lot with cardiac catheterization? It is the best, most diagnostic procedure on the heart. We can actually look inside the coronary arteries with a cardiac cath. We can look inside the heart. We can do pressures. We can do all kinds of things. But there's a lot of teaching that goes on with a cardiac cath if you read your book. You got to teach them about safety before, and then you have to teach them about what's going to happen to them, how they're going to feel when the dye is going in or the catheter is going through their heart. It may cause them to feel warm and weird. They may have a metallic taste in their mouth. They may cough. So you need to prepare your patient. So read that section on cardiac cath. The most danger to the patient can also occur in the after the cath, because they can actually, what can happen to them? Can they bleed?
Internal bleeding?
Internal or external bleeding, period. And so how do you know somebody's bleeding? If your
Blood pressure drops.
Their blood pressure drops. So blood pressure, a low blood pressure on a test would be a big indication. And so what if they break loose and start bleeding? What do you need to do immediately as the nurse?
Hold pressure.
Hold pressure to the site. We used to teach you do it 1 inch above the puncture site where they went in and put it down, but now we just say put pressure on the site, because it was just too much trouble trying to get it contained in the right location. So everybody was like, where? And look, blood, steady pumping. Get a glove on, get a gauze, and push. Make sense? All right. So all those things we talked about with cardiac caths are important. Here's some other little cute things about thrombolytics. Do you need to read page 778?
Yes.
Do you need to know absolute contraindications?
Yes.
Now let me just see if you can think. It'll also have some relative contraindications, and to me, those are the no-brainer things. But to you, it might not be. I found out it wasn't to some new nurses one day, just at clinical. If you have a patient whose blood pressure is 200 over 114, you got a high pressure, are they more apt to what?
Stroke.
And bleed. If you have a patient who had a heart cath and their sheath is still in them, and they're thinking about pulling it, don't. If their blood pressure is elevated, go, hey, I think I'd leave that in until you got their blood pressure down. Because as soon as they pull the sheath out of the groin, what do you think is going to happen?
Goes two out.
Thank you. So just, well, I don't care you want to get them out of there because they're an outpatient. They ain't going to go nowhere if they're doing what?
Bleeding out.
Hello? You're going to be there even longer. All right. So don't rush it. Get something to get their blood pressure down before you pull anything. Because are they at risk for bleeding if their blood pressure is high?
Yeah.
So we're going to do what before we give thrombolytics?
Check blood pressure.
And if their blood pressure is really high at the moment, are we going to give it? No. Okay, so read 778. So nursing care with thrombolytics and with patients. Let me just mention this real quick. If they're going to get thrombolytics, as a nurse, we have to go ahead and do every invasive thing that patient may need. Such as, if we think they're going to need an NG tube, go on and put it in them before the thrombolytics. If we think they need an IV, you better get them on in there before the thrombolytics. Does that make sense? Because are they going to bleed like a stuck pig if you start trying to stick something in them? So you got to really think. We don't want that patient, if we give thrombolytics, they shouldn't receive like IMs or anything invasive for so long after the thrombolytics. I think y'all can think like that, and then I didn't say it, and then I'm like, oh. Okay, so we're going to make sure that you know all that. I'm not reading slides to you, okay?
778 is a little bit wrong page.
This is the book that I have, that I was told that y'all have. So if you are behind, then you're in the edition lower than this. This is the book. Oh, I got that.
We have 9.
Can I see? Over here.
I was told y'all are in this book.
Okay.
Yep. Make sure you update your books. It's okay. Just update your books. You know how to update your books on Evolve? Update. In this book, it's 778. That's why I brought it in here. It's heavy. I had to carry this. But anyway, here it is, and that's why I brought it. Because this is always, this ain't my first rodeo.
All right, Jamie.
Just saying. That book thing drives me crazy every semester. All right. So the complications of an MI, here's what I want you to hear. After someone has an MI, what can happen to them, listen to me, is they get better. We put them on anticoagulants. We put them on antiplatelets, especially after they have thrombolytics. There's a bunch of, if you dissolve a clot, parts of that clot's called thrombin. And so little pieces of that clot are in their blood. So we have to put them on like heparin and aspirin to try to do what? Clean it all out. And so they'll be on that for a few days. And that's, you know, with a STEMI that we did thrombolytic therapy. And we also do that after heart casts sometimes. And you do it. So the point of the story is, after that, we have to get that patient ready to go home. And we have to make sure they're going to be okay. So we put them on a heart monitor, right? We're monitoring them and everything, and we start increasing their activity. And then we start kind of rehabbing them. And we do it pretty quick. So it's important you teach a patient that just had a heart attack that if you have any chest pain or discomfort or the signs and symptoms that you had before that brought you here, that you need to report it immediately. Because of all those little things floating around in their blood, can they have another heart attack?
Mm-hmm.
Can they extend the heart attack they had just had?
Mm-hmm.
Yes. So you got to teach those patients, because I have seen this more than once. The patient had an MI, they came in, we treated them for it. They were up in their room getting ready to go home, and they started feeling bad again. And you ask them, they go, oh, I'm fine, it's the same old stuff. And they think that's normal. I've seen that in a few patients almost die going home, because the complication of an MI is that they can extend or have another MI. So you've got to teach them that it could be another problem. Is not, whatever that discomfort is not coming from the initial MI. You're having another one. So it could be another problem. So do you think that's important?
Mm-hmm.
All right. So here's some other things that can happen following an MI based on where the heart muscle was damaged. If part of the muscle that was damaged was their SA nodes, they ended up with a pacemaker. I mean, if the part that was damaged was their valve, do you see where I'm going? All right. So the worst thing that happens following an MI is there was a significant amount of heart muscle that died, like 40% or greater, and they are in cardiogenic shock. That is what cardiogenic shock is. It's more 40% or more of their ventricle is dead. And so this is probably one of the bad things that can happen and decreases the patient's quality of life. And so those patients end up in the ICU, and they end up with left ventricular assist devices on life support, and we have to figure out how to get this heart functioning where they can live. And in some cases, they need a heart transplant. It's sad. And that's one of the reasons they die. All right, so cardiac rehab, there's all that stuff. We start inpatient, and if their insurance will pay, they go outpatient, but most insurances do not. It sucks. Sorry. That was not professional. But it used to, and that's why it makes me mad, because that was an excellent program. So we got to teach a lot about diet, activity limitations, teach family how to do CPR. We have to teach the patient about activity tolerance. We teach the same activity tolerance spiel to heart failure patients that we teach to post-MI patients. Is, you know, you're going to have to progressively increase your activity. I always do this. I draw a little heart, I put a 20 for myself, and I started laughing. I said, I'm going to come in here and do this for y'all. And put little legs on it. I go by the rule of 20. When I have a heart patient, then I'll put it back down, but I wanted you to see the little heart right there. I use the rule of 20. If I get them up and I'm trying to get them to progress their ambulation and their blood pressure drops 20 systolic, they are not tolerating that activity. Or if their blood pressure drops after I get them back to the room, 20 systolic, then they are not tolerating the activity. If their pulse goes up more than 20, they are not tolerating the activity. If it goes the other direction, 20, we're in trouble too. Does that make sense? So again, typically what you're going to see is their heart rate's going to go up. So use your rule of 20, and that will help you. Now, it should be a no-brainer that if you're getting them to walk and progress their activity and they have chest pain, they are not tolerating the activity. Or if they get nauseated or tell you they're dizzy, they are not tolerating the activity. Are y'all good with that? Okay. There's a reason. All right. Keep going. So these patients that have a significant MI are going to need a lot of help getting ready to go home because they are scared to death to go home. All right, so now, almost break time, isn't it? Is it? 10 minutes. No, they're peeing now. Dang it. Okay, heart failure. What do you remember about heart failure? Left and right. Left and right. We use CHF term a lot when we're talking about left-sided. That's an old term. It's not even in your books, I don't think, anymore. The C part. They say heart failure. And so the deal with this is the doctors will write diastolic failure or systolic failure. You don't have to know that. I want you to focus for your NCLEX on left-sided failure and right-sided failure, and understand that left-sided failure means what kind of signs and symptoms? Respiratory. The worst form of left-sided heart failure is called
Pulmonary edema.
Very good. What's the first thing you do with someone in pulmonary edema?
Listen to them.
What's that position called?
High Fowlers.
High Fowlers. And what else would you do for someone who is experiencing pulmonary edema, which is an emergency that you have to act on immediately?
Supplement oxygen.
Oxygen.
Probably put a pulley and throw some Lasix in them bags.
Would you
Lasix,
suction?
Diuretics. Only if you see it bubbling out their mouth, and they can't, because you will suck all the other oxygen that they have. They're freaking out and feel like they're drowning. So if you go in there and start sticking something else in their mouth, unless you feel like they're choking on it or something. So we're going to put them up high. We're going to dangle their legs down. Why would we be trying to dangle their legs? You got to make sure they got a blood pressure before you do that. Well, so we're trying to displace the fluid downward. Okay, if they're in heart failure, that bad, experiencing pulmonary edema, they probably have a little right-sided failure too now, because left side leads to right-sided failure. All right. So we're going to give them diuretics. What else might we give them? Morphine. Why morphine?
Pain and breathing.
Heart rate.
It's gonna slow your respiration.
Guess what else morphine does? And it's the reason we give it for acute. We give it for acute coronary syndromes too, right? Remember, Mona? The M part is. Guess what it does? It decreases preload and afterload because it causes vasodilation. And so if it causes vasodilation and decreases preload and afterload, will that help the pulmonary edema patient? Yeah. It also helps with pain. And it also blocks them, helps to decrease, don't let me say the word block, it helps to decrease sympathetic nervous system stimulation. You have to watch morphine that you don't give a huge dose all at once, because if you give a huge dose all at once of morphine, you're going to knock out their what? Breathing. Okay, and their blood pressure. Okay.
You said to decrease the preload and afterload?
Yes, and remember the preload, because it makes their tank bigger.
Yeah.
All their vessels bigger, so there's going to be less fluid going into the heart.
Yeah.
So that decreases preload because the tank's bigger.
Yeah.
And then because the tank's bigger, the heart will have an easier push out because it's not real skinny.
It's not constricted.
Right, so and it's dropping the pressure. So it decreases preload and afterload. So all you got to remember is it causes vasodilation. And that's a good thing for a pulmonary edema patient. And that is why we give morphine to a pulmonary edema patient. Left-sided heart failure. So what are the causes of it? Look up there. What causes it? 'Cause I don't want it.
High blood pressure.
That's the main one. We see so much of that, it's not even funny. And coronary artery disease. And every once in a while, we'll have a patient that has valvular disease. And of course, if the valves on the left side of your heart don't work, your blood can't keep going forward like it's supposed to, can it? If the doors won't open or close and keep the blood going the right way, then you're going to have backup either way. And if you have backup in the left side of your heart, you have left-sided heart failure. You with me? Think about it like that, and you'll get every test question right. The valves, you'll have the valves down pat. Okay? All right. So here's a cute little picture about left-sided heart failure and all the things that the patient may experience, because some of the signs and symptoms of heart failure cross over left and right. Because you can have fatigue with both. You agree?
Yeah.
So you can have blue, I love cyanosis. If you see cyanosis, we in trouble. You know, that's a late sign. You can see tachycardia with both. You can see confusion with both. Confusion is a sign of decreased perfusion to the
Brain.
brain. And so that makes sense, don't it? But all the other things are related to breathing. All right. Right-sided. Look what causes right-sided heart failure. Left-sided heart failure. And then if they have an MI that affects the right side of the heart, then they're going to go into right-sided heart failure because the right side of the heart squeeze good. Because if the muscle is dead, it can't work. And it can't conduct electricity. Right. All right. Pulmonary edema can also cause, pulmonary hypertension can also cause right-sided failure. So where are all the signs and symptoms of right-sided failure?
The body.
The body. So y'all remember all this really good. What does anorexia mean?
Not wanting to
eating,
eat.
because their belly's so big they ain't got any room. Okay. So the problem that we have in heart failure, either side, is, and this is why you kind of have to have a basic understanding of heart failure, is your body's compensatory mechanisms are going to kick in like mad. And so when the body senses that it's not getting enough perfusion, then it activates the renin, angiotensin, aldosterone system. And what that does is it makes it worse. And also, your body's sympathetic nervous system is going to be stimulated because of the stress on the body. So now are you starting to see why all these meds are given to these patients? Because they affect these systems that make this stuff worse. So we have to block them. So that's one of the things I want to mention. In your reading on heart failure, it talks about how we stage heart failure. And you might have noticed there's a bunch of different staging. Like after an MI, they do the kill-up staging, and then there's another staging in your book. Here's what I want you to know. Don't memorize all that. What I want you to know is, in the early stage of heart failure, all we see in a patient, the only thing we see, is that their sympathetic nervous system is activated. And how do we know that? Because, you remember the sympathetic nervous system division? Remember the chemical mediator was the gas pedal, and it had adrenaline as what is put out. And I told you as my mama said. And the other word for adrenaline was epinephrine. Y'all remember that?
Mm-hmm.
And remember the bear in the woods and how your heart rate goes up? Well, guess what? The early stage heart failure patient has a little tachycardia and a little bit of a fast respiratory rate because their sympathetic nervous system is stimulated related to the body trying to compensate for what's starting to happen to it. Does that make sense? So in early stage heart failure, what are you going to see?
Decreased respiration, increased heart rate.
And the larger the number is on the staging system, the worse it is. Stage 4 heart failure is cardiogenic shock, which is the worst form. Okay, which meant 40% or greater of their heart muscle is dead. And so the stages, the lower the stage, the better. Does that make sense? So you don't have to memorize all that. We know about BNP. Y'all already told it to me. There's a good little slide if you don't. what causes, what are all the causes? Let's talk about some that we ain't talked about yet. Oh, yeah, I forget, we're great. Good time. Amen.